Good evening to all different section heads, training officers, and our dear guests and fellow trainees for gracing this first roundtable discussion in this fiscal year during the peri-COVID times. I am Jarmi Ribugio, third year fellow in training. May I call in Dr. John Quirol, training officer, to formally welcome you all.
Good evening, everyone. In behalf of our section head, Dr. Domingo Ganson, we would like to welcome all the PSMO training institutions. I would like to introduce our staff, Dr. Jinjin Ong Cornel, Dr. Che Ferreras, Dr. Chiki Galvez, Dr. Paul Pua, Dr. Mamo Ortines, Dr. Gigi Kindipan, Dr. Sharon Sandoval, Dr. Amy Bagino, Dr. Dana Rosuelo, and Dr. Roland Yumon. They're all helping us in training our 3 fellows. Lung cancer, in particular the non-small cell lung cancer, has a lot of changes for the past 10 years. The role of actionable driver mutations and the role of immunotherapy. Likewise, in small cell lung cancer, there's a role of your immunotherapy in improving the quality of life and prolonged survival. So for tonight, we're going to share a case of small cell lung cancer, and let's all learn from this case. Thank you.
A pleasant evening to everyone. I am Christine Marie Chua, and I will be presenting a case of small cell lung cancer. Our objectives are the following: to present a case of small cell lung cancer and its management with emphasis on first-line chemoimmunotherapy. We will also highlight recommendations on prophylactic cranial irradiation and thoracic consolidation RT. Our patient is a 62-year-old male from Nueva Vizcaya, non-hypertensive, non-diabetic, smoker of 80 pack years, non-alcoholic beverage drinker, with no family history of cancer, previously worked as a barangay kagawad, who came in with a chief complaint of chronic cough. History of present illness started 3 months prior to consultation when the patient experienced dry cough associated with 10% progressive weight loss, fatigue, and exertional dyspnea. It is not associated with hemoptysis, fever, hoarseness, dysphagia, chest pain, orthopnea, headache, nausea, vomiting, and bone pain. On physical examination, patient demonstrated an ECOG-1 with normal vital signs. Pertinent findings include no venous distension of the neck and chest wall, no facial and upper extremity edema, no plethora, no lymphadenopathy with bibasal crackles, normal rate, regular rhythm, non-tender abdomen, no palpable mass, no noted neurologic deficit. Chest X-ray was done, which showed a homogeneous opacity in the right upper lobe. Well-defined nodular and mass-like densities are seen in the left upper and middle lung field and the right lung base. Pneumonia with probable consolidation on the right upper lobe. Other tests showed that the patient exhibited adequate marrow, renal, and liver reserve. Hepatitis profile showed previous hepatitis B infection. LDH and amylase are within normal limits. Patient is presently in euthyroid state. On chest CT scan with IV contrast done Feb 16, 2021, there is a fairly defined lobulated heterogeneously enhancing mass in the right hilar region and posterior segment of the right upper lobe, measuring approximately 8.9 by 6 by 5.9 centimeter, which likely represents a primary lung neoplasm with multiple lung nodules. Medially, it extends to the mediastinum, encasing the SVC. Superiorly, it extends to the apical segment of the right upper lobe, and anteriorly, it extends to the anterior segment of the right upper lobe. CT-guided fine needle aspiration biopsy was carried out on March 11, 2021, which showed positive for malignant cell, favor small cell lung carcinoma. Small cell lung cancer is 15 to 20% of lung cancers. Tobacco exposure causes small cell lung cancer in over 97% of cases, and small cell lung cancer incidence rate mirrors smoking pattern. In the past 30 years, the incidence of small cell lung cancer has been slowly declining in the US from 17 to 13%, with 1986 as the peak number of cases. This also shows that the initial strong male predominance among small cell lung cancer patients in 1973 has steadily decreased over the subsequent 20 years. In 2002, the male to female ratio of patients with small cell lung cancer was 1:1. Although there are fluctuations from year to year, there is an overall trend toward increased survival of patients with extensive stage small cell lung cancer. In 1973, 1.5% of all patients with extensive stage survived 2 years. This number increased to 4.6% by year 2000. In the Philippines, lung cancer is the number one cause of cancer mortality. In one lung cancer registry data from 2000 to 2008, it showed that 87% of lung cancer patients have non-small cell carcinoma, while 10% are due to small cell lung cancer. Mortality rates of around 70% were seen in all patients regardless of the variables. Comparison of death rates by histopath showed no difference. For our first poll question,
Good evening to everyone. I will be presenting the immunocytopathologic findings of the pulmonary mass FNOB specimen of our patient for tonight, which was processed and signed out in another institution. The tumor cells in the FNOB smears are mostly overlapping in cohesive clusters. In this particular cluster, the tumor cells have oval to irregular and darkly staining nuclei. Most of them do not have a lot of cytoplasm, and nucleoli are generally inconspicuous to absent. The chromatin material inside the nuclei appear granular with alternating dark and light staining areas. In this cluster, nuclear molding is prominent, in which the tumor cells are so closely pressed against each other that they appear to conform to the nuclear contours of their neighboring cells. Also pointed is a lymphocyte for size comparison. Here it appears that most of the tumor cell nuclei are 2 to 3 times the size of the lymphocyte nucleus. In the cell block preparation, we see a clearer picture of the general tumor architecture, in which the tumor cells are lined up in a picket fence fashion at the periphery of this tumor trabecula, and the tumor cells seem to be forming gland-like or rosette-like structures, represented by the holes at the tips of the yellow arrows. Necrotic material is likewise present in the hemorrhagic background. The institution assigned this FNOB case as positive for malignant cells favors small cell carcinoma and suggested a panel of immunohistochemistry stains consisting of chromogranin, synaptophysin, TTF1, and BER-EP4 for a more definitive diagnosis. The institution that signed out the FNOB proceeded to perform the suggested immunohistochemistry stains on the submitted FNOB specimen. First is TTF1, an antibody that we commonly use to help establish a pulmonary tumor primary, which showed positive, strong and diffuse nuclear expression and brown staining in the tumor cells. All the light blue staining cells in the background are red mixed inflammatory cells, which are negative for TTF1 expression. The small box in the upper right corner is the positive control, which shows how positive staining should look like in the cells. Next is BER-EP4, an epithelial marker which showed strong and diffuse cytoplasmic membranous expression in the tumor cells. The tumor cells show diffuse and intermediate to strong cytoplasmic expression for the neuroendocrine marker synaptophysin. The tumor cells are also positive for the neuroendocrine marker chromogranin, in which they showed patchy, weak to intermediate immunoreactivity. Ki-67 is a marker that we usually use to provide us an estimate of the proliferative index of a tumor. And here we see that approximately 50 to 60% of the tumor cells show immunoreactivity as shown by the brown staining in the tumor cell nuclei. The final sign-off of the institution for this case was immunomorphologic features compatible with neuroendocrine carcinoma. And according to them, given the immunomorphologic features, a neuroendocrine carcinoma of lung primary is most likely, but correlation with clinical findings and ancillary tests to rule out metastasis is highly recommended. For my next few slides, I will be giving an overview of the pathology of neuroendocrine carcinomas of the lung, and towards the end of my presentation, I will be touching a bit on PD-L1 expression and tumor mutational burden in small cell lung cancers. In cytology specimens, what alerts us pathologists to the possibility that we may be dealing with a neuroendocrine tumor is the characteristic chromatin pattern that our textbooks commonly refer to as salt and pepper chromatin, in which the chromatin inside the tumor cell nuclei appears as a mixture of dark and lightly staining granular material. We readily see the typical architectural patterns of neuroendocrine tumors in tissue biopsy or resection specimens, such as trabecular growth and pseudorosette formation. All of these are actually examples of small cell carcinoma, in which individual tumor cells have scant cytoplasm and darkly staining oval to spindly nuclei. Many of the cells here show the characteristic granular salt and pepper chromatin pattern with absent nucleoli, but some cells are so small that it is difficult to visualize the nuclear chromatin. Nuclear molding is apparent, in which the tumor cells appear to be pushing against and conforming to the shapes of adjacent cells. The World Health Organization classifies neuroendocrine tumors of the lung into 4, each with different prognostic implications and treatment strategy. All of them may present with varying degrees of neuroendocrine morphologic features, which I have discussed previously, like salt and pepper chromatin, trabecular growth pattern, pseudorosette formation, nuclear molding, and small cell carcinomas. Typical and atypical carcinoids are considered as low-grade tumors with absent to focal necrosis and low mitotic activities and Ki-67 indices, while large cell neuroendocrine and small cell carcinomas, being high-grade tumors, usually have extensive necrosis and consistently high mitotic rates and Ki-67 indices. Although morphologic features are characteristic, immunohistochemistry may be required for confirmation of the neuroendocrine and/or epithelial nature of the tumor cells. The distinction between a small cell and a large cell neuroendocrine carcinoma is made based on cytologic criteria, since they have similar immunohistochemistry and genetic profiles. Although cell size in small cell is generally less than 3 times the size of a lymphocyte and more than 3 times a large cell, the most useful differentiating features are the amount of cytoplasm, which is scant in small cell and abundant in large cell, and nucleoli, which is absent in small cell and present or prominent in large cell. Inactivation of the tumor suppressor gene TP53 and RB1 is uniformly seen in all small cell lung cancers. And the smoking-related etiology is strongly supported by the characteristic tobacco-associated molecular signature, which is characterized by a very high mutation frequency, as well as a high proportion of guanine to thionine transversions in the tumor DNA caused by aromatic hydrocarbons. On the right is a surplus plot representation of the genome of a small cell carcinoma cell line way back in 2010, with the chromosomes oriented in a clockwise direction. Here we see widespread somatic mutations throughout the genome, insertions and deletions represented by the tiny green rectangles, substitutions, which are all the light and dark orange bars, copy number variations shown by the blue lines, and chromosomal rearrangements, which are all the purple and green lines at the center of the plot. It is well known that upregulated expression of programmed cell death ligand 1 or PDL1 is one of the survival mechanisms employed by cancer cells, which enables them to evade immune recognition and destruction. PDL1 immunohistochemistry is an FDA-approved companion diagnostic test for immune checkpoint inhibitors such as pembrolizumab in various cancers. As pathologists, what we do in interpreting a PDL1 immunohistochemistry is to evaluate the staining in tumor cells and our tumor-infiltrating lymphocytes and macrophages and come up with a tumor positive score or TPS or a combined positive score or CPS. On the right are pictures of small cell lung cancer cases, the top two of which are positive for PDL1 expression and the bottom two of which are negative for PDL1 expression. These meta-analyses on the prevalence of PDL1 expression in small cell lung cancers included 27 studies with a total of 2,792 patients enrolled. They found that the reported prevalence of PDL1 expression in the studies varied widely, ranging from 0 to 83%, with a pooled estimate of prevalence of PDL1 expression at 26%. FDA recently approved the PD-1 inhibitor pembrolizumab for the treatment of tumor mutational burden high or TMBH solid tumors. TMB is defined as the number of mutations per megabase or total genomic area analyzed. Compared to tumors with low TMB, tumors with high TMB tend to have more immunogenic neoantigens, and this genomic signature can help determine a patient's likelihood of responding to immunotherapies. This graph shows the percentage of tumors among a total of 30 solid tumors with high mutational burdens using Foundation 1 CDX, which is the first FDA-approved companion diagnostic to measure TMB and help identify patients who may be appropriate for treatment with pembrolizumab. Consistent with other published studies, among the tumors with the highest frequency of mutations on the right are those that tend to have environmental exposure-driven mutations such as melanoma and lung cancers. In this analysis of the response rates to PD-1 inhibition across 27 different tumor types using pooled response data from the largest published studies that evaluated the objective response rate. As would be expected, tumors such as mismatch repair deficient colorectal cancers and cutaneous malignancies that tend to have the highest tumor mutational burdens also have the highest response rates. The small cell lung cancers in this analysis had around 10 mutations per megabase, which is considered to be TMB high, but had response rates of only a little bit over 10%. Data from these two studies suggest the potential role of TMB as a biomarker for immunotherapy response in lung cancer patients. In this study on small cell lung cancer, the objective response rates of patients with high TMB were higher in both the monotherapy and combination therapy groups compared to patients with low or moderate TMBs. While TMB is a promising predictive biomarker for patient selection for immune checkpoint blockade, this analysis failed to support the hypothesis that a single TMB threshold can be used in patient selection across all tumor types and suggested that future studies should focus on improving cancer type-specific assessment of TMB from targeted sequencing and cancer type-specific activity of immune checkpoint blockade in TMB-high tumors before clinical implementation. That will be all for my presentation. Good evening and thank you very much for your attention.
PET-CT scan was done on March 23, 2021, which showed that there is a large right hilar mass extending into the middle and posterior mediastinum. Noted pulmonary nodules. There are multiple enlarged lymph nodes that are present in supraclavicular, upper paratracheal, para-aortic, left hilar, and left interlobar regions. There are multiple varices enhancing non-calcified pulmonary and pleural-based soft tissue nodules and masses that are scattered in both lungs. The largest mass on the right is present in the medial basal segment of the right lower lobe, measuring 2.1 by 3 by 2.8 centimeters. The largest mass in the left is present in the left hilar region, measuring 3.6 by 2.9 by 3.4 centimeter. There are several hypoattenuating lesions that are present in both liver lobes. Lytic lesions are noted in the right humeral shaft, posterior rib, and the sacral area. Cranial CT scan with IV contrast showed no intracranial hemorrhage, no hydrocephalus, no midline shift, and no enhancing intracranial mass lesion. For our second poll question, a two-stage system introduced by the Veterans Administration Long Study Group has historically been utilized instead of the TNM. Limited stage is defined as a disease confined to one hemithorax that can be encompassed in a tolerable radiation field that can be safely treated with definitive radiation doses. While extensive stage is a disease too extensive to treat with definitive radiation. The use of TNM system is most clinically useful for cases of early stage disease in whom surgical resection may be considered. In TNM staging, limited stage corresponds to stage 1 to 3, while the extensive stage is stage 4. For the tumor stage of our patient, we have a tumor that is more than 7 centimeters and multiple tumor nodules in both lobes, which corresponds to T4. For the nodal stage, there are metastases in the contralateral mediastinal, contralateral hilar, and supraclavicular lymph nodes, making it N3. For the M stage, noted multiple extrathoracic metastases in multiple organs like the bone and in the liver, which corresponds to M1C. Our final diagnosis is small cell lung cancer stage 4B, clinical T4M3M1C, AJCC 8 edition 2017, extensive stage by Veterans Administration Lung Study Group, status post CT-guided fine needle aspiration biopsy of the lung mass, March 11, 2021. We have a patient with extensive stage without localized symptomatic sites or brain metastasis, with a good performance status of 1. Our initial treatment would be a combination systemic therapy, including supportive care. For our third poll question,
in the past decades, the landscape of the management of advanced small cell lung cancer has changed a little. This timeline illustrates the paucity of new treatment options for patients with small cell lung cancer over the past 3 decades. The red shaded boxes represent standard of care therapies that have been approved by the FDA. Since 1985, no significant progress has been made, and platinum-based chemotherapy has for a long time represented the standard of care. Disease relapse usually happens within 3 to 6 months since completion of chemotherapy, and median OS is approximately 12 months, illustrating the need for new, innovative, and effective therapy options for extensive stage small cell lung cancer. Much disappointment was felt when none of the multiple trials using other agents showed significant improvement until recently. Immunotherapy has dramatically modified cancer treatment across several malignancies and has been an active area of investigation in small cell lung cancer. There are a lot of reasons to be optimistic that adding immunotherapy to chemotherapy in small cell lung cancer will be helpful. First, the increased incidence of paraneoplastic autoimmune phenomena suggests that small cell lung cancer is an immune disease. Therefore, potentially a good candidate for treatment with immune checkpoint inhibitors. Interestingly, small cell lung cancer patients that present with early paraneoplastic syndromes, such as cerebellar degeneration, limbic encephalitis, and Lambert-Eaton syndrome, have a more favorable prognosis. Second, small cell lung cancer proved to have increased genomic instability with high tumor mutational burden and neoantigen load, both potentially drivers of immunogenicity. Loss of function mutations in p53 and RB1, which are tumor suppressor genes, are difficult to therapeutically target. Small cell lung cancer cells have the potential to reduce the histocompatibility complex or MHC antigen expression and to inhibit infiltrating lymphocytes, inducing an immunosuppressive tumor medium. By contrast, cytotoxic chemotherapy is able to induce immunogenic cell death, leading to cross-presentation of tumor antigens to T cells. Combining ICI with chemotherapy, therefore, might counteract immune suppressive tumor mechanisms and therefore restore immune responses. It has been a long time since we've had a breakthrough in small cell lung cancer, and we are finally seeing some real concrete improvement in survival with first line therapy. After years of heartbreak and minimal improvement, we're beginning to see these breakthroughs happen. Recently, new standards of care were established in the first-line therapy of extensive-stage small cell lung cancer based on phase 3 randomized clinical trials. But before that, let's have a poll question number 4 and number 5. This timeline shows how much enthusiasm was devoted to the use of immune checkpoint inhibitors in the first-line therapy of extensive-stage small cell lung cancer. Our discussion for tonight will highlight the randomized phase 3 studies for which our current treatment landscape is patterned. The earliest data of an immune checkpoint inhibitor combination in the frontline setting for the extensive stage small cell lung cancer came from the randomized phase 3 IEMPOWER 133 trial, which evaluated atezolizumab plus carboplatin etoposide, followed by maintenance atezolizumab versus placebo, plus chemotherapy followed by maintenance placebo in patients with previously untreated extensive stage small cell lung cancer. Patients were stratified by sex, performance status, and presence of brain metastasis at enrollment. Only treated asymptomatic brain metastases were eligible. The co-primary endpoints were overall survival and progression-free survival by investigator assessment. Baseline characteristics were well balanced between groups. A pre-planned updated overall survival analysis with an additional 9 months of follow-up was conducted, now with a median follow-up for overall survival of 22.9 months. Exploratory biomarker analysis according to PD-L1 expression levels on both tumor cells, or TCs, or tumor-infiltrating immune cells, or ICs, were conducted in the biomarker evaluable population. Updated Kaplan-Meier estimates for overall survival in the intention to treat population show that the median overall survival was 12.3 months in the atezolizumab and 10.3 months in placebo. Overall survival at 12 months demonstrated a survival increase of 12.9% in atezolizumab compared with placebo. Similarly, at 18 months, 13% patients were alive in the atezolizumab than in placebo. An updated analysis of median progression survival was 5.2 months in atezolizumab and 4.3 months in placebo. Consistent with results observed at the primary analysis, the addition of atezolizumab was associated with consistent overall benefit across the majority of subgroups. Again, with previously reported results, there appeared to be an imbalance in overall benefit among patients with baseline brain metastasis compared with patients without. The number of patients enrolled in the study with brain metastasis was small, which may be because of the requirement that brain metastasis should be treated prior to enrollment. Among 346 patients with available blood-based tumor mutational burden status, hazard ratios were 0.73 and 0.73 for blood-based tumor mutational burden scores less than 10 and greater or equal to 10, and 0.79 and 0.58 for scores less than 16 and greater or equal to 16. The PDL1 biomarker evaluable population comprised only 34% of the intention to treat population. PDL1 was mostly seen on tumor-infiltrating cells and limited expression on tumor cells. This finding differs from that of non-small cell lung cancer, for which PDL expression is observed on both TCs or ICs. Baseline characteristics in the BEP are generally well balanced. Among the 137 patients with available PDL1 status, median overall survival among those with PDL1 expression on tumor cells or tumor infiltrating immune cells less than 1%, greater or equal to 1%, and greater or equal to 5% was 10.2 months versus 8.3 months, 9.7 months versus 10.6 months, and 21.6 months versus 9.2 months. Regardless of PDL1 expression, an OS benefit was observed. Safety profile is consistent with the defined toxic events of the individual agents as previously demonstrated in the interim analysis. The most common grade 3-4 related to the trial regimen were neutropenia and anemia. Immune-related adverse events occurred in 7 to 9 patients in the atezolizumab group and in 48 patients in the placebo group, for which rash and hypothyroidism being the most common. In conclusion, atezolizumab plus carboplatin etoposide continued to demonstrate an improvement in overall survival for first-line extensive stage small cell lung cancer with 22.9 months of follow-up. Exploratory biomarker analysis that included both PDL1 IHC and blood TMB suggests that patient-derived treatment benefit from the addition of atezolizumab regardless of biomarker status. The second phase 3 trial of frontline chemoimmunotherapy in extensive stage small cell lung cancer was a 3-arm Caspian study, which compared durvalumab plus platinum etoposide versus durvalumab plus tremelimumab and chemotherapy versus chemotherapy alone. Patients with brain metastasis were eligible at an IMpower 1-3, provided they were asymptomatic or treated and stable without steroids and anticonvulsants for at least 1 month before study entry. Patients were then randomized to 1:1:1 ratio to receive durvalumab plus platinum etoposide, durvalumab plus tremelimumab plus platinum etoposide, or platinum etoposide alone. Durvalumab maintenance therapy was given in each of the 2 durvalumab arms. Unlike IMpower 133, Caspian allowed both carboplatin and cisplatin to be used. The primary endpoint was overall survival. The median age was 63 years, and most patients were men, current or former smokers, and had a stage 4 disease diagnosis. At baseline, 10% had brain metastasis and 39% had liver metastasis. At data cutoff, the median duration of follow-up for overall survival in censored patients was 14.2 months. Outcomes were very similar to those seen with atezolizumab in IMpower 133. Durvalumab improved median overall survival from 10 to 13 months. The Caspian trial met the primary endpoint for overall survival in June 2019, reducing the risk of death by 27%, which formed the basis of the US FDA approval in March 2020. Median progression-free survival in the durvalumab plus chemotherapy was 5.1 months, and with chemotherapy alone, 5.4. Updated results, including the primary analysis for overall survival with durvalumab plus tremelimumab plus platinum etoposide versus platinum etoposide alone, was published in December 2020. Durvalumab plus tremelimumab plus platinum etoposide was not associated with a significant improvement in overall survival versus platinum etoposide As per pre-specified statistical plan, median overall survival was 10.4, with durvalumab plus tremelimumab plus platinum etoposide versus 10.5 with platinum etoposide alone. The overall survival benefit observed at the interim analysis for durvalumab plus platinum etoposide compared with platinum etoposide was sustained. In this updated analysis, the hazard ratio for overall survival was 0.75. These updated results from the Caspian trial show a remarkable 22% of patients still alive at 24 months, showing a sustained and meaningful improvements in survival and prolonged treatment response. Although durvalumab plus tremelimumab plus platinum etoposide did not show a significant difference in overall survival compared with platinum etoposide, the tails of the overall survival Kaplan-Meier curves for both immunotherapy groups were similar, with more than 20% of patients estimated to be alive at 24 months in each group. The sustained benefit is particularly noteworthy in this aggressive disease setting. The hazard ratio for overall survival was consistently favoring durvalumab plus platinum etoposide versus platinum etoposide across all pre-specified patient subgroups as observed at interim analysis. The rates of grade 3-4 adverse events was 62% in each arm. The most common grade 3 or 4 adverse events were neutropenia and anemia, similar in IM power 133. The most common immune-mediated adverse events were hypothyroid and hyperthyroid events, which were all grade 1 or 2 in severity. In conclusion, updated results from the randomized open-label phase 3 trial showed sustained overall survival benefit with the addition of durvalumab to platinum etoposide in patients with extensive stage small cell lung cancer compared with a robust control group after median follow-up of more than 2 years. The addition of tremelimumab to durvalumab plus platinum etoposide did not significantly improve outcomes in this trial. The phase 3 Keynote 604 study randomized patients to pembrolizumab plus platinum and etoposide, followed by maintenance pembrolizumab, or placebo plus chemotherapy, followed by maintenance placebo until disease progression. Similar in IM Power 133 and Caspian, no unstable brain metastases were enrolled. However, a tumor biopsy for PD-L1 assessment was mandatory, unlike Caspian and IM Power 133. Primary endpoints were overall survival and progression-free survival by blinded independent review. Median age was 65 years, 74% had ECOG1, and more patients in pembrolizumab plus platinum etoposide arm had baseline brain metastases. At the time of second interim analysis, adding pembrolizumab to chemotherapy led to a significant progression-free survival advantage with a 25% reduction in the risk of disease progression or death. However, at final analysis, overall survival in the intention to treat population narrowly missed the threshold of significance, with a 20% reduction in the risk of death for the combination. In subgroup analysis, progression-free survival and overall survival benefit was seen irrespective of PD-L1 expression. Adverse events were as expected, mostly what we would expect with the addition of immunotherapy to chemotherapy, without any significant worsening of hematologic toxicities from chemotherapy. Overall, Keynote 604 is supportive of the findings from the IM Power 133 and Caspian trials, although we do not have regulatory approval yet to use pembrolizumab plus chemotherapy as a standard of care. At its latest updated version, this is a treatment landscape in the management of extensive stage small cell lung cancer adopted by NCCN and ESMO. And for our last poll question, In the early 1970s, the brain was assumed to be a pharmacologic sanctuary where subclinical metastases were protected. It was suggested that cranial irradiation might prevent the development of clinically evident brain metastases. In early small trials, there was a decrease in the rate of brain metastasis but no improvement in survival. A multicenter phase 3 randomized trial aimed at showing a difference in the outcome between patients who underwent prophylactic cranial irradiation and those who received no further therapy was conducted in 2007 by Slotzman. After 4 to 6 cycles of chemotherapy, all patients have to have a response as judged by the standard treatment policy of each participating center. Radiotherapy had to start 4 to 6 weeks after chemotherapy. The primary endpoint was the development of symptomatic brain metastasis. There were no significant differences between the two groups with respect to the characteristics of the patient. Median age is 62 years, and more men with ECOG1 were enrolled in this study. At data cutoff, symptomatic brain metastases were observed in 16.8% in the irradiation group and 41% in the control group. The cumulative risks of symptomatic brain metastasis at 6 and 12 months were 4.4% and 14.6% respectively in the irradiation group and 32.0% and 40.4% in the control group. This study shows a clear advantage of cranial irradiation with respect to the incidence of symptomatic brain metastasis. This reduction is greater than the hazard ratio of about 0.5 reported in previous trials. Cranial irradiation was generally well tolerated, and side effects did not show influence of patients' self-assessment of their global health status. Side effects in the irradiation group were hair loss and fatigue. No significant difference was found between the study groups in role functioning, cognitive functioning, and emotional functioning. An exploratory analysis of the remaining quality of life scales showed differences of nearly 10 points for appetite loss, nausea and vomiting, and leg weakness. With this, PCI is a standard of care after any response after chemotherapy. As in iEmpower 133 and the control arm of Caspian and Keynote 604, PCI should be part of the standard treatment. However, because of the absence of brain imaging before enrollment and variations in therapeutic regimens and irradiation doses, concerns have raised about these findings. Conflicting data come from a phase 3 trial from Japan, a randomized open-label phase 3 study at 47 institutions reassessing the efficacy of prophylactic cranial irradiation in the treatment of extensive-stage small cell lung cancer. The analysis included 224 patients enrolled and randomly assigned. Participants at baseline characteristics, including initial chemotherapeutic regimens before enrollment and response to initial chemotherapy, were well balanced between the two groups. Median age is 69 years old. More patients were male with ECOG 0 to 1. They were partial responders and had received 4 cycles of platinum etoposide. Patients with any response assessed after completion of 2 or more cycles of initial platinum-based doublet chemotherapy were enrolled. All patients have had MRI and thoracoabdominal CT scan within 4 weeks before enrollment. Prophylactic cranial irradiation had to be started between 3 to 8 weeks after the start of the previous cycle of chemotherapy. The primary endpoint for comparing prophylactic cranial irradiation with observation was overall survival. Prophylactic cranial irradiation did not increase overall survival compared with that in patients who did not receive prophylactic cranial irradiation. Although the incidence of brain metastasis was higher in the observation group than in the prophylactic cranial irradiation group in our trial, this did not result in shorter survival in the observation group, by contrast with the previous study. Anorexia, nausea, and malaise were frequent and severe in patients in prophylactic cranial irrigation group beyond 3 months after randomization. As a recommendation, therefore, when patients can be periodically assessed by MRI examination during follow-up, prophylactic cranial irrigation is not essential for patients with extensive stage small cell lung cancer with any response to initial chemotherapy and a confirmed absence of brain metastasis by MRI. Physicians in countries other than Japan should be cautious when extrapolating the results of this study to their general practice. Based on the conflicting trial results from Japan and the EORTC, the NCCN SCLC panel recently softened the recommendation for PCI in patients with extensive stage small cell lung cancer to consider either PCI or surveillance brain imaging. There is paucity of data on the integration of PCI and immunotherapy. In the IMpower 133 study, PCI was allowed in the maintenance phase and 22 patients in each arm received PCI. Intrathoracic tumor control remains a major difficulty after chemotherapy, with 75% of patients having persistent intrathoracic disease, and roughly 90% had intrathoracic disease progression within the first year after diagnosis. A phase 3 randomized controlled trial at 42 hospitals, known as the CREST study, evaluated the role of thoracic radiotherapy in addition to PCI for patients with extensive stage small cell lung cancer who had responded to chemotherapy. Any response after 46 cycles of standard chemotherapy with no clinical evidence of brain, leptomeningeal, or pleural metastasis, and with no previous radiotherapy to the brain or thorax, were enrolled. The primary endpoint was overall survival at 1 year. Secondary endpoints were intrathoracic control and toxic effects. Thoracic radiotherapy was combined with PCI and was started on average 1 week after PCI. The mean interval between the chemotherapy and prophylactic cranial irrigation was 32 days. Baseline characteristics were much the same in each group. Median age at 63 years, more men with ECOG1 were enrolled. By contrast with the EORTC study on PCI, which used an inclusion age limit of 75 years, no age restriction was used, with 8% of patients older than 75 years old. Overall survival at 1 year was 33% in the thoracic radiotherapy group versus 28% in the control group. The difference between groups was not significant. Median overall survival was 8 months in both groups. At 18 months, survival was 16% versus 9%. However, at 2 years, overall survival was significantly improved with 13% patient alive in thoracic radiotherapy group and 3% in the control group. Intrathoracic progression was less common in the thoracic radiotherapy group than in control group. That's almost 50% reduction in the intrathoracic recurrences. Intrathoracic progression, either with or without progression elsewhere, occurred in 43.7% in the thoracic radiotherapy group versus 79% in the control group. Thoracic radiotherapy was well tolerated and recorded no severe acute or late toxic effects. Compliance was high with 95% of patients completing protocol-specified thoracic radiotherapy without interruption. CREST study recommends that consolidative thoracic radiotherapy appears to mainly benefit patients with residual thoracic disease after systemic therapy, but with low bulk extrathoracic metastasis disease that has responded to systemic therapy. There is paucity of data on the integration of thoracic RT and immunotherapy, and this should be explored in future research. Hence, the current recommendation, adopted in its updated version in NCCN and ESMO.
To recap, we have a 62-year-old male, an 80-pack-year smoker, diagnosed with extensive stage small cell lung cancer. Patient had his first chemoimmunotherapy cycle on April 5, 2021 with IM Power 133 protocol with bone support. The patient tolerated the first cycle with no adverse events. Then the patient received his second cycle on April 26, 2021, in which he again tolerated very well. Patient demonstrated even better performance status with significant decrease in coughing episodes and weight gain of 2 kilos. The plan for the patient is to receive 2 more cycles of chemoimmunotherapy as in IM Power 133 protocol. With response of primary tumor and distant metastasis to induction therapy, patient is set to receive a maintenance atezolizumab and PCI and thoracic consolidation RT. For tonight's key takeaways, small cell lung cancer accounts for about 15% of all lung cancers and represents one of the most aggressive malignancies associated with a fast tumor growth rate, early metastatic spread to distant sites, and a strong association with tobacco. The addition of an anti-PD-L1 inhibitors, atezolizumab or durvalumab, to first-line platinum etoposide represents an important therapeutic advance for extensive disease small cell lung cancer patients. Currently, no predictive biomarker is available, and program death ligand 1 and tumor mutational burden testing are not recommended. In patients achieving a response after chemotherapy and a performance status of 0 to 2, RT to the residual primary tumor and lymph nodes is a treatment option. And lastly, in patients with extensive stage small cell lung cancer without brain metastasis on brain MRI after chemotherapy and who can be followed up with regular brain MRI, PCI may be omitted. Thank you.